From Microbe TV, this is Infectious Disease Puscast, episode 51, recorded on March 27th, 2024. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. And I will share with everyone that Daniel's bow tie has prions on it today. We're both wearing red, though. We're matching.
Well, that could be your new job. You can be the one who shares, because Vincent always asks on TWIV clinical updates. So, tell us about your bow tie. Apparently, people are interested. So, as we were telling our video audio editor, these are the kind of misfolded proteins that will get into your brain and make you crazy, demented. He's already halfway there. So. But no, really a tragic disease. So, yeah. Ugh. Well, all right. What shall we do now?
Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting, or entertaining. So on to the literature, shall we?
All right. Well, we will start with viral. And I certainly found this first paper both interesting and entertaining. The article, Oral Administration of Obeldesivir protects non-human primates against Sudan Ebola virus, recently published in Science. And I pronounce it that way specifically, so people would maybe see a little bit of a connection there. But my friend and colleague at UHG, John Hitt, brought this one to my attention. And there is a great editor's summary by Caroline Ash. So for those of you that are not going to actually read the whole article, let me share that summary with a few edits. Filoviruses frequently emerge to cause terrifying outbreaks of often fatal human disease. When we're talking about filoviruses, we're talking about things like Marburg and Ebola. Treatment options so far have focused on monoclonal antibodies, mostly. Remdesivir is an adenosine analog that binds viral RNA polymerase to block replication by premature termination of RNA transcription. And this drug, right, those are probably familiar. That drug, remdesivir, has been successfully used intravenously for treating progressive severe acute respiratory syndrome coronavirus 2, SARS-CoV-2 infections in humans, so COVID-19. In this article, the investigators tested a related oral prodrug, obeldesivir, currently in phase 3 clinical trials for COVID-19 treatment in non-human primates for its therapeutic value against filoviruses. And there's even an associated perspective by Sprecher and Van Herp. I'm going to leave links to all this stuff. Now, when administered to animals within 24 hours of virus exposure once daily for 10 days, orally, the drug conferred complete protection against lethal infection with Sudan Ebola virus. And I will say, agree, having an oral drug would be a major logistical advantage for use in the remote, resource-poor areas where filovirus occurs. And so they have a nice graphical abstract apparently put together by BioRender. And it's probably worth looking at because, I mean, it sounds great. You say, oh my gosh, 100% survival, but you got to actually compare because if you look at different studies, and actually the original article has some references to these, what was their survival in folks that didn't get treated versus did get treated. And it's really interesting. And I think what I like here is they point out with the filoviruses, much like SARS-CoV-2, it's not the acute issue. It's that cytokine storm that comes later that is really the issue with a lot of these. So really, really great article and really nice advance there.
That figure that you have is excellent. I really love it. All right. Well, I took my viral paper from Transplant ID, Presentation, Management, and Outcomes of Norovirus in Adult and Pediatric Solid Organ and Hematopoietic Stem Cell Transplant Recipients, a multi-center retrospective study. So norovirus, which I feel like is going around, everyone knows it can be awful, really for anyone, but in particular can cause this chronic relapsing course with chronic diarrhea, and prolonged viral shedding in our transplant patients. And so I have certainly struggled to treat patients with this. And this paper provides the largest, it seems like, retrospective study to date of both adult and pediatric transplant patients. So the NIH has funded a phase 2 randomized placebo-controlled clinical trial of nitazoxanide for acute and chronic norovirus infections in stem cell and solid organ transplant recipients that are over the age of 12. But it sounds like there were a lot of delays in getting the study started. And then, of course, it overlapped with COVID when there were less cases. So the team, it sounds like, pivoted and did this multi-center retrospective study across 8 sites. So these are the groups that were participating in the randomized trial. So the paper included any solid organ or stem cell transplant recipient at least 1 month of age with symptoms that fit with norovirus and a positive stool PCR. The cases were from 2017 to 2021, and they included those who were in the randomized trial, but also some that were not. They identified 280 patients. 3/4 were adult, and the other 25% were pediatric. Majority were solid organ transplant recipients, so 91%, and most of those were kidney transplants. And so norovirus was typically diagnosed late post-transplant, a median of about 36 months afterwards. And so that makes you think of community-acquired infections, which I think is not surprising. In children, the cases did occur earlier after transplant. 2/3 of patients had at least 3 diarrheal episodes a day. And then something that I guess I thought anecdotally based on seeing patients, but also is represented in this paper, that pediatric transplant patients are more likely to have the sort of fever vomiting phenotype, where a lot of the adults had significantly longer periods of diarrhea. Most patients required hospitalization, typically for their GI symptoms, and AKI was identified in 6.5% of patients. And then elevated serum calcineurin inhibitor levels were also noted in 39% of these patients. And so in transplant, we often talk about that terribly vicious cycle of diarrhea and then renal impairment, and then your tacrolimus level goes up, and just kind of a terrible spiral. Sadly, there was no obvious treatment in the paper, similar to what I think most of us think, that has led to sustained improvement. And it sounds like there were pretty variable approaches in how people manage patients. It seems like the order of what they would do is, 1, reduction and or discontinuation of the mycophenolate and or ImmTOR calcineurin inhibitor, although this resulted in inconsistent improvement. And, the thought would be this increases the risk of rejection, although they didn't identify specific rejection related to adjustment and immunosuppression in the study. The next most common thing that folks did was giving antimotility agents like loperamide, and then the third was trying nitazoxanide, which, it wasn't sort of in-depth studied here, but it only led to a sustained resolution of symptoms in about 1/3 of patients. So they have a really nice visual abstract summarizing the paper as well.
All right. Yeah, it would be really nice to have better tools for
Yeah.
norovirus, not only for our patients. I know I had a bad case of norovirus within the last year, and it was like right before we went on vacation, and so I sort of, the quote unquote, you got to soldier on because we're heading to Arizona. And in the airport, I'm going up the escalator, and I'm like not doing well. And I just actually fell over backwards. And if it was not for a good Samaritan, that might have been the end of Dr. Griffin. So. All right. My wife grabbed the suitcase to protect people, but fortunately, a good Samaritan caught me on the way down. But okay, moving on to bacterial. Be sure to listen to This Week in Microbiology. The article, Bacteremia from a Presumed Urinary Source in Hospitalized Adults with Asymptomatic Bacteria, was recently published in JAMA Network Open. Now, can we make the title The Absence of Bacteremia, please? These are the results of a 5-year, 68 hospital cohort study of 1,590 hospitalized patients with asymptomatic bacteria, only 1.4% developed bacteremia from a presumed urinary source, while 72.2% received empiric antibiotic therapy for urinary tract infection. In the 2,126 patients with bacteriuria with altered mental status, but no systemic signs of infection, right? We run this scenario over and over again. Less than 1%, only 0.7% developed bacteremia from a presumed urinary source. So even less. So in general, the point here is to reinforce that we should not be treating asymptomatic bacteria with it getting treated 72% of time. It's non-evidence-based standard of care, I guess. To dig deeper on multivariate analysis, there are some risk factors. Male sex, we've got an adjusted odds ratio for that bacteremia. If we see hypotension, okay, I'll buy that. 2 or more systemic inflammatory response criteria, adjusted odds ratio 1.72. So if they actually have some suggestion that they are infected. Urinary retention, okay, that's a risk factor. Fatigue, or probably the biggest two here, if they have leukocytosis, we're going to give an adjusted odds ratio of 3.38, pyuria, adjusted odds ratio of 3.31 for associated bacteremia. So a little bit different if that altered mental status is also associated with signs of a systemic inflammatory response, leukocytosis, pyuria, but really a challenge as they report that asymptomatic bacteriuria is really rarely associated with bacteremia, occurring in less than 1% of patients. So, perhaps a challenge for us here to rein in all that antibiotic use in this arena. I don't know, Sarah?
Well, I feel like this is part of being an ID doctor is telling people this. And now I guess I have a paper to show. I mean, I think it's a challenge because we often come in after the fact and are asked to provide input. And I think once people have sort of closed in on this is from a urinary tract infection, it's really hard to break that.
Yeah, it's so hard to step back when this starts to be entrenched, right? There was a sort of senior ID doc that I trained under who he treated asymptomatic bacteria all the time. And then if you stop doing it, they'll stop calling you. And I'm like, yes, that might be good. But you should get them to stop treating this. So, all right.
Yeah. Well, I put this next paper right next to yours because it's somewhat related. In the Lancet Infectious Diseases, they published a paper, A Reference Standard for UTI Research, a Multidisciplinary Delphi Consensus Study. So the authors were aiming to provide a consensus on a reference standard for UTI applicable to adult women and men, including older patients, with hopes to sort of use this for further studies focusing on bacterial UTI, excluding indwelling catheters. So for some background, they had a core group of 11 experts, so from the Netherlands, US, UK, Germany, and Hungary, and that was a mixture of ID, geriatric docs, urology, primary care, EM, and microbiology. So that core group made the questionnaire rounds and created this reference standard, and then they ultimately invited 62 experts, of which 3/4 or 46 people agreed to take part. The final expert panel had a mix of primary subspecialties and countries, and there was a 94% consensus on the reference standard and their key recommendations. So these are what they were. So signs and symptoms of UTI. New onset dysuria, urinary frequency, and urinary urgency were most indicative of UTI. Non-specific symptoms should not be included in the definition of UTI, and that this reference standard can be applied to patients who are unable to express or experience symptoms. And I'll come back to this in a second. Recommended against the term of complicated UTI and distinguishing instead as UTI with or without systemic involvement, which I actually quite like that. Quantification of pyuria was encouraged, and the threshold of 200 leukocytes per microliter was introduced. They also recommended a threshold of 10 to the 4 CFU per ml for midstream urine samples, and 10 to 3 if E. coli cultured or if the sample was obtained through an in and out cath. And so they have a flow chart that assigns points to distinguish definite, probable, possible, and not a UTI, which I won't really go into. But the first branch point is the patient capable of expressing or perceiving lower urinary tract symptoms? And I think that's the area where sometimes folks are asking these questions. If the answer is no, you move down and it says, does the patient have pyuria? And if the answer is yes, they have a box where you can add up points to get a UTI score to fall into either definite, probable, possible, or no UTI. I think the common question that comes up is the example of an older patient who has pyuria or bacteriuria who's either asymptomatic or they can't communicate their symptoms because they're confused. In that case, a patient in this algorithm, or maybe algorithm's not the best word, this chart is that patient can receive a classification of possible UTI. It is meant to try to account for the high background prevalence of asymptomatic bacteriuria in older patients. But I mean, it sounds like the group struggled and debated how to classify patients in this scenario. So you could look at this, negatively and say that's less than ideal if that truly is asymptomatic bacteria. I think you could also spin it positively of, they're trying to provide possible UTI for those rare occasions where a patient truly can't communicate and you really don't know if they started off with urinary symptoms. Overall, I think this is a really nice resource and there's plenty to either like and or debate amongst yourselves. But I thought my take home to just say to everyone is that this is meant to be a reference standard for research and not a clinical decision tool. I feel like sometimes when we get these definitions for research, people latch on to them, but they're not always meant to be directly, transferable into clinical practice. So still need us ID docs around, I guess.
No, I like that actually, except I noticed I was nodding along and I'm always so critical of a Delphi consensus. And so, okay. Well,
Yeah. I actually was surprised they couldn't get more folks to be a part of the consensus because, I think they had plenty of people, but sometimes they have these huge Delphis that are like hundreds of folks. So anyways,
yeah, I was
you'd
trying
think
to,
that many people would want to talk about UTI, but that might just be a
I would, you and I, right? Call, I've
ID
talked about,
centric.
I
Yeah.
don't know. Maybe it was I was trying to figure out, was it a geriatric physician or a geriatric specialist when you were giving me the mix of ID doctors? Maybe it was
Sorry, geriatrician.
Anyway, okay, no. So the next article, Aspiration Pneumonia and the Associated Benefits and Harms, published in Chest. What could we possibly be talking about when it comes to aspiration pneumonia? Well, antibiotics with extended anaerobic coverage are used commonly to treat aspiration pneumonia, which is not recommended by current guidelines. So these are the results of a multi-center retrospective cohort study across 18 hospitals in Ontario, Canada, from January 1st, 2015 to January 1st, 2022. Patients were identified or included in the physician-diagnosed aspiration pneumonia. Patients were then grouped into two different groups, right? So our limited anaerobic coverage, that's what you're supposed to be doing. They received ceftriaxone or cefotaxime or maybe levofloxacin. And then we had patients who were categorized into the extended anaerobic coverage group. Well, we'll see, but that's not what has been recommended. And they were in that group if they got moxicillin clavulanate, moxifloxacin, that's that fluoroquinolone that's supposed to cover some anaerobes, or if they got ceftriaxone, cefotaxime, levofloxacin, but someone also threw on some Clinda or metronidazole. My big question is, where are all those folks who get vancomycin? Isn't that the standard of care for all maladies? Well, the primary outcome was all-cause in-hospital mortality. Secondary outcomes included incident C. diff colitis occurring after admission. The LAC and EAC, right, so that's our limited versus expanded anaerobic coverage group, included 2,683 and 1,316 patients, respectively. So pretty robust. In hospital, 814 patients, so 30.1% in the LAC, limited anaerobic coverage, 422 or 32.1% in the extended anaerobic died, right? So just to kind of give you that 30% when you're doing it the way recommended, 32% with the extended died, respectively. So other big thing, C. diff colitis occurred in 5 or fewer patients, and 11 to 15 in the different groups, respectively. So 2 to 3 times as many when you're using that extended. After overlap weighting of propensity scores, the adjusted risk of the extended versus the limited was 1.6 for in-hospital mortality and 1.0 for C. diff colitis. So just to pull all that together, the authors conclude that extended anaerobic coverage is unnecessary. It is not associated with an additional mortality benefit, but it is associated with harm, with a clear increased risk of C. diff colitis in this study. So, all right, the article, Systemic Review of Household Transmission of Strep A potential site for prevention that has eluded attention, recently published in JID. And I think many of us feel like we know all about this. But to be honest, what literature are we referring to when we talk about toothbrushes and the rest of those recommendations? Well, we see here the literature that confirm contact transmission via skin to skin and sexual, vehicle transmission with anal shedding and transmission via bedding, transmission from a cat, and a bunch of household transmission where it's not exactly clear how it was spreading around. Reading this article, I'm going to agree with the authors that conclude we do not really know as much about this important topic as perhaps we should, and they suggest more research is needed.
Love it. I have a mini review from Antimicrobial Agents and Chemotherapy entitled Updated Antimicrobial Dosing Recommendations for Obese Patients. I'm not going to really go through all of it. I mainly wanted to point this out as a future reference for folks. There's a really nice figure 1, and in the paper they discuss background info and physiologic changes that affect serum antimicrobial concentrations. But table 2 is this like multi-page mega chart with recommended dosing, and then notes on whether therapeutic drug monitoring is recommended or other remarks. So another nice resource. I feel like there was recently another similar paper that maybe we talked about on Puscast, but definitely save this one and refer to it later.
All right. The MMWR CDC Laboratory Recommendations for Syphilis Testing, United States 2024. Now, this came out in February, so I'm a bit late in presenting. It really is worth reading and goes deep into the weeds. I think that was a really good febrile on syphilis, but ultimately, a high point is the direction with regard to how we should be testing for syphilis, a growing issue here in the U.S. And they basically say that each algorithm has advantages and disadvantages, but both are acceptable. And they walk us through figure 3, the traditional algorithm. We start off with your RPR, and then if it's reactive, then you get that treponemal test. The reverse sequence algorithm, where you actually start with that treponemal serological test, and then if it's positive, then you get your RPR. It's sort of interesting. Colombia, we are still very traditional. You have no option otherwise. The other parts of my life, we are moving forward with the reverse sequence algorithm. Now, what do they say? They say that the traditional algorithm might be less sensitive in detecting early or late latent syphilis, although an increase in false positives may occur when applying the reverse algorithm in low prevalence populations. Sort of interesting that it's flipped between Columbia there and Washington Heights, which might be a higher prevalence population, dare I say. Now, the development of antibodies that react with the non-treponemal, so the lipoidal antigen, and treponemal tests may take up to 2 weeks after primary infection with T. pallidum. serological tests that measure antibodies in both non-treponemal and treponemal antigens related to syphilitic infection, as we're seeing here, should be used in combination when the primary test is reactive. Sole reliance on just one reactive serological test can lead to misclassifying a patient's syphilis status. And I just sort of want to point that out, right? Because we think, oh, but that treponemal is so specific. But if you've got a positive treponemal, but a negative nonspecific, so lipoidal, you really got to call into question, right? So both the traditional syphilis screening algorithm and the reverse syphilis screening algorithm are acceptable. And the preferred algorithm should actually be based on laboratory resources, including staff, space, and cost, test volume, patient population served. And that's going to vary on location. All right. Now, we also have the article, Predictors of Mortality of Streptococcal Bacteremia and the Role of Infectious Disease Consultation, a retrospective cohort study published in CID. And I know Sarah's going to have a comment. I grabbed this knowing that if I didn't, she would. Now,
we're obligated to include these in all podcasts. So if you write a paper about how ID consultation is important, just, send it to me.
So we will definitely discuss it. But come on. Is it really fair to manage bacteremic patients without expert guidance? In this study, they find that infectious diseases consultation within 48 hours of bacteremia, that's okay. There's no rush. Just 48 hours, bacteremia onset was associated with, you ready for this? A 71% reduction in 14-day mortality. Come on. Shouldn't this be mandatory at all centers?
And I think in this paper, obviously that is like a very extreme result, but we're very good at adjusting antibiotics to call us. But it also highlighted our ability to convince people to go for source control when it's needed early on. I feel like that was a big reason why there was a difference in this paper, is the patients who didn't get early source control. So just give us a call. We can nag about source control anytime.
Yeah. No, I think we've got to come up, sort of our soapbox, but we've got to come up with a solution. 80% of counties in the United States do not even have a single infectious disease provider. So huge challenge there. We need to create some way of providing access to our just tremendous expertise. But then, boy, in areas where we are, give us a call. Come on.
Yeah. Well, I will take us into our fungal section. I pulled two interesting papers. The first one is a Nature Reviews disease primer on invasive candidiasis, which not surprisingly gives a really great overview. They really focus on data from the past 5 years. So if you look at box 1, they sort of summarize the 6 most clinically relevant Candida species, which are not all Candida anymore. So Candida albicans, Candida parapsilosis, Pichia Kudravzevi, Kruzii, I'm sticking to that, Nagasomyces glabratus, or Candida glabrata, Candida tropicalis, and Candida auris. So there's a lot of, good reminders about risk factors for invasive candidiasis, which are kind of classically broken into buckets in my mind of, proliferation or colonization with Candida, and things that sort of push towards that, like broad spectrum antibiotics, being on a mechanical ventilator, being, spending a long time in an acute care facility or in the ICU, breaches in skin or mucosal barriers, so burns, surgery, and so on, and then either intrinsic or acquired immunosuppression. There's a really nice map on the geographical variation and distribution of Candida species, which I thought was really cool, and I actually learned a little bit more in detail. For example, I did not know that Candida glabrata was, it seems like more frequent in older patients. So 22% of it, of cases seem to be in patients who are over the age of 70. And they think that's kind of why there's a higher geographical distribution in high income regions with aging populations, whereas Candida parapsilosis more frequently infects neonates and infants. Or maybe I knew this and I forgot. I don't know. There's tons of info on pathogenesis and virulence factors, as well as diagnosis and treatment, that I'm not going to go into detail. But I will point out there's a specific treatment issues of various Candida species section towards the end, which is particularly helpful pointing out when there is resistance to certain, for example, azole antifungals. So I put the picture of the map so folks can take a look at that. And another wonderful, again, image-packed fungal paper is from the Lancet Microbe, Impact of Climate Change and Natural Disasters on Fungal Infections. So many fungi are thriving as Earth temperatures increase, quickly adapting to higher temperatures and becoming more virulent. We talk about it a lot, spreading to expanded geographic ranges. The authors walk through climate change impact on fungal diseases such as adaptation of the fungi to heat stress, impact on fungal ecosystems, resistance, and host susceptibility. There's actually some notes in there about threats to food security, which I thought were interesting. And they also wrote about the impact of epidemiology of fungal infections, which, again, we've mentioned in a lot of papers on Puscast. And then the second half, they focus on specific sort of natural disasters and fungal outbreaks. So Figure 3 shares a nice graphic on mechanisms by which natural disasters can trigger fungal outbreaks, such as traumatic injuries, dispersal like the wildfire smoke in California, and aftermath such as high levels of moisture and humidity or flooded housing, things like that. And then kind of related to that, Figure 4 shows this global distribution of outbreaks and natural disasters. So just some really awesome visuals and a really sort of broad overview of how these changes related to climate change are a global issue.
Yeah, it's a great article. I was excited
The
to see
graphics, they're
that
beautiful.
included. Yeah, so
I
read them,
love them.
everyone.
Yeah.
All right, parasitic. Be sure to listen to This Week in Parasitism. I think we had an exciting last one that will drop soon where we talk about Wolbachia. So if that doesn't raise your, All right, we have the dispatch from Emerging Infectious Diseases, acanthamoeba infection, and nasal rinsing, United States, 1994 through 2022. Look at that, 28 years of stuff. Let me start with the headline. The CDC published a report that for the first time connects acanthamoeba infections to neti pots and other nasal rinsing devices. As a result, officials renewed their warning that extremely rare but potentially deadly consequences can come from flushing nasal passages with common tap water. Yes, here this report describes 10 patients with non-keratitis acanthamoeba infection who performed nasal rinsing before becoming ill. All were immunocompromised. 7 had chronic sinusitis. Many used tap water for nasal rinsing. CDC recommendations for performing safe nasal rinsing include using boiled, sterile, or distilled water. If tap water is used, it should be boiled for a minimum of 1 minute or 3 minutes in elevations of greater than 1,980 meters and cooled before use. All right, there you got it.
I think a lot of people don't realize I would ideally not use tap water. I feel like whenever I ask patients, it seems like a surprise. All right. And then for our miscellaneous section, I have the new ASCO, which is American Society of Clinical Oncology guideline on vaccination of adults with cancer, which was published in the Journal of Clinical Oncology. This review builds off of what is now archived IDSA 2013 guideline, but they recommend immunizations for these patients to include seasonal flu, RSV for those over the age of 60, COVID, Tdap, or TD with boosters, hepatitis B, recombinant zoster vaccine, the pneumococcal vaccine, which is either 1 dose of PCV20 or PCV15 followed by Prevnar 8 weeks, PPSV23 8 weeks later, and then the HPV vaccine. So ideally, these would be given at least 2 to 4 weeks before starting therapy. However, non-live vaccines can be given at any time during or after starting chemo or immunotherapy, hormonal treatment, radiation, or surgery. As for revaccination after stem cell transplant, there is a little bit of variation in the existing guidance that's out there, specifically about whether, immune predictor guided vaccination is more likely to produce a protective effect versus a standardized schedule. In these guidelines, they recommend complete revaccination starting for most vaccines at 6 to 12 months after your stem cell transplant in order to restore vaccine-induced immunity. A couple specific notes here. The 3-dose primary COVID series flu and pneumococcal vaccine, which ideally would be PCV20, can be started as early as 3 months after your transplant. There's less data on the use of recombinant zoster in our allo stem cell transplant patients. These sort of recommend giving the vaccine at the end of antiviral prophylaxis, which is generally a year to a year and a half after an allo and 3 to 12 months after an auto stem cell transplant. And then, they have some other guidance in there about other vaccinations that are recommended. There's no specific recommendation on the RSV vaccines at the moment in this setting. And then they recommend live vaccines like MMR and varicella should be delayed for at least 2 years and only given in absence of active GVHD or immunosuppression. And then the other sort of takeaways, they do recommend adults with hematologic malignancies receiving CAR T-directed therapy against B-cell antigen should get flu and COVID vaccine no sooner than 3 months after therapy, and then non-live vaccines after 6 months. And then there's some guidance on travel vaccinations, as well as reinforcing that household members and close contacts should be up to date on vaccinations as well when possible to help protect your patient.
Yeah, it gets pretty complicated. So you sort of appreciate why we have special ID physicians for these transplant folks. All right, let us close out with the article, Clinical Impact of Multiplex Molecular Diagnostic Testing in Children with Acute Gastroenteritis Presenting to an Emergency Department, a multi-center prospective study published in CID. So as the title suggests, these are the results of a prospective multi-center, ready for this, stepped wedge trial to determine the impact of multiplex molecular testing at 5 academic children's hospitals on children presenting to the emergency department with acute gastroenteritis. So I'll encourage everyone to spend a little time on, Wikipedia, whatever you want, understanding this stepped wedge approach, because it's really this interesting approach where it allows one to step in with an intervention and compare it to prior to that intervention. So it allows you to get a lot more people exposed to the intervention, if you want to view it that way. So here we read that potential pathogens were identified by clinician-ordered tests in 3.3% in the pre-intervention period, compared with, you ready for this, 74% in the intervention period. That seems, I don't even need a statistician to tell me that 74% is better than 3. And, gets even better, the intervention was associated with a 21% reduction in the odds of any return visit, as well as a doubling of appropriate treatment. So, which is amazing. I was talking to one of my colleagues who's urgent care doc, and, it's amazing, the stool cultures that are ordered that never come back positive, multiple stool O&Ps that never come back positive. And, here we've got this wonderful new test that, as we can see, improves our ability to actually know what we're doing. Imagine that. And actually reduce the odds of coming back. And ER visits are not cheap. And also, boy, as a parent, one of the last things you really ever want to do. So, all right.
I always feel a little conflicted about the multiplex stool
I know
panels.
you do, Sarah.
I know. Well, the pediatrician and the transplant doc in me wants an answer, but I also realize I probably don't always need them. But
if you don't get
I
that
will
answer,
remain conflicted.
the parent wants that answer, and if they don't get an answer, they might just come on back.
Yeah, I know.
And if the doctor is less sophisticated than you and they don't have an answer, who knows what they're going to do?
Yeah, I know. Well, on that note, it brings us to the end of Puscast. As always, the references for the show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, at microbe.tv/Puscast, or grab it with your favorite podcatcher. We love to get your questions, comments, and paper suggestions, and any article that just suggests how incredibly valuable an IV consultation is. Send them to puscast@microbe.tv. And if you like what we do, or you just want us to keep doing it, consider supporting these science shows of Microbe TV at microbe.tv/contribute, or parasiteswithoutborders.com and click on the donate button.
I'm Sara Dong. You can find me at swindong or at febropodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.